Good morning. Thank you all for showing up this morning. I'm sure y'all probably didn't have anything better to do this morning, huh? Probably put off that golf game to come out and learn a little bit. Well, I'll tell you what, let's get started so we can learn a little something together. We're going to talk about a variety of topics, primarily the importance of early diagnosis of heart disease and really of cardiovascular disease, because we're going to touch on vascular disease as well as heart disease. And we'll as we go along, we'll talk about the distinction between the two. And even toward the end, we'll discuss even venous disease, all right? And we'll touch on that right at the end. We will have some time for questions toward the end as well, okay? Well, let's get going. When we make the distinction of cardiovascular, the reason we add the vascular component is because really when we dealing with the heart, we're primarily dealing with the blood vessels of the heart. I mean, that's really what people are trying to avoid is a heart attack. And the way we have a heart attack is when those blood vessels clog up and a clot forms, and next thing you know, we're having a heart attack. Well, in addition to that, the blood vessels in other parts of the body can clog up as well. And what has happened over the years, peripheral vascular disease or peripheral arterial disease, which had been traditionally under the realm of the vascular surgeons, has now become more commonplace, dealt with by cardiologists. In fact, when I finished my training in '93, we had peripheral vascular training even back then. So even though a lot of times you're cardiologists, you're going there for them to treat your heart, a lot of them have backgrounds in treating peripheral vascular disease as well. So this is I guess you could say a relatively new concept, but it's not that new after all. And this is a diagram of the venous system. You remember the venous system carries blood away from the extremity back to the heart, or from an organ back to the heart, whereas the arteries carry it away from the heart. And so we'll talk a little bit later on about diseases of the veins as well. Now, what is vascular disease or heart disease? Well, primarily we're focusing on the arteries and the blockages that build up in these arteries. And everything is centered around trying to figure out if you have blockage and how much blockage you have. This image to the right here is an example. If you were to take a major blood vessel in the body and fillet it open, this is what some of that plaque will look like. Okay? It's a fatty substance that in some cases almost has a cornmeal texture to it. And so this is why when people are doing any kind of procedure on the heart or on the vascular system, a lot of times we can't see this. You see, we're blinded when we're going in there, and sometimes these little pieces of this can break free, and this is where some of the complications can occur. So that's why it's very important to generally start out with non-invasive type testing before we move on to more invasive type testing. So statistically, heart disease continues to be the #1 killer in our country. Although we've made some gains in that treatment, cancer still represents a distant second. Now, as we approach our middle ages, or middle age, generally 1 in 3 adults are going to have some form of cardiovascular disease. All right? It may not be something that you feel, but there is plaque development going on somewhere in your body, whether it's the coronaries, whether it's the legs, whether it's the carotid arteries, or some of the cerebral vessels. Now, where does Louisiana rank in the United States as far as death rates from cardiovascular disease? Well, as you can see, the states with the red color have the highest rates of death rates of cardiovascular disease. And once again, Louisiana ranks at the top. And I think a lot of that has to do with a number of issues, but a lot of cultural reasons, our diets, the food is so darn good here. I think that's part of the problem. All right? Now, how are we doing as a medical community? Are we impacting heart disease? And the answer is yes. If you look at these statistics, you start out in the 70s where heart disease was really at its peak. That's really when bypass surgery and balloon angioplasty and a lot more aggressive treatment for the risk factors of heart disease became more prominent. So you notice in the 80s and 90s, these numbers start to continue to trend downward. Really, it's in the 90s when the statin drugs were introduced. And I think that's had a huge impact on the management of heart disease. But again, all of our stents and bypass surgeries, all of the opportunity to make those diagnoses before people actually die from disease has had a big impact. Now, you may ask yourself, why was the heart disease rates so low back in the early part of the century? Well, back then, infection really killed most people. A lot of people didn't live long enough to develop heart disease and die from it. The other thing, too, is McDonald's and Burger King weren't around back then either. Now, are you at risk for heart disease? That's a question we all have to ask ourselves, and it's important to arm ourselves with information to know if we're at risk or not. And if we are, we really need to do something about it. Now, as we all know, smoking is probably one of the most devastating things we can do to our bodies. Okay? By far, I see more problems in smokers than any other population. And also, hypertension plays a big role. Diabetes is huge as well. If I had to pick two things that devastate the body more, I would say smoking and diabetes. And when you combine those two together, it's like a time bomb. Also, obesity and, of course, poor diet. Here again, some more risk factors. Inactivity, couch potatoes, okay? Not a good thing. The human body is a body that needs to be moved. We need to stay active, okay? Unfortunately, people, as they move up in their careers, they move from maybe a job where there's a lot of walking around the facility to behind a desk. And what ends up happening, they gain weight because they're not as active. Next thing you know, you've got diabetes and hypertension lurking. Well, the other thing is, let me go back here, is stress, okay? Here's a lady who looks pretty stressed out. Early on in my career, I really did not appreciate the impact of stress on disease states, but obviously cardiovascular disease states. And as I've been doing this now for a while, I've come to appreciate the stress factor is huge. In fact, I've seen people show up with heart attacks who actually have no blockage. And they're having a heart attack after a very emotionally intense experience. Okay, maybe a family argument. Or I had one lady who thought she had killed her dad from an insulin overdose. Literally, she showed up in the emergency room with a heart attack. Once we opened things up, we realized there was no blockage. It was simply the artery just spasmed off. And so that's what stress and intense emotions can do for us. The type A personality, okay? Anybody know this guy? All right? A little bit of him in all of us, I guess. A lot of people who are very successful in business and in life are often type A types. And this type A personality can lead to various types of disease, but primarily heart disease. Adrenaline, when we're stressed and real hyper, we're constantly pouring out adrenaline, and that has a negative effect over time. Now, we can categorize all these risk factors in modifiable and non-modifiable risk factors. Okay? We'll start with the non-modifiable risk factors, and those are fairly straightforward. Generally, as we cross the age of 45, we're considered at risk for heart disease. All right? If I were to look at if I could just take the arteries of every 45-year-old male and open them up and look at them, we'd probably find a little bit of plaque in about 95% of them. Okay? A very small amount. Okay? However, that is not going to hurt you until probably 30 years later, but it just depends on where you fall with all these risk factors. Male sex, family history. Generally, when a female dies before the age of 65 and a male dies before the age of 55, that's considered a risk factor. However, if you're now beyond those age groups, let's just say you're 70 years old and you have multiple family members who had heart attacks or bypass surgery in their 70s, well, guess what? You're at risk for that too. Okay? Really, part of this is aimed at the younger folks. You know, if you're 30 years old, 40 years old, we're trying to get those folks to recognize the fact that they may have certain risk factors and do things about them. You know, obviously, once you've lived past this age group, you still need to look at your family history and your risk factors because of the reason we just discussed. Now, when you look at the modifiable group, obviously, hypertension is something that we can treat. Tobacco, again, like I said, probably one of the most devastating things we can do to ourselves. Diabetes. Diabetes, a lot of times it's something that's in our family, but a lot of times it's a result of us being overweight. Okay? And a lot of folks who end up losing, let's just say you're 100 pounds overweight, you lose the weight, guess what? The diabetes goes away. So that is also something that can be treated as well. Cholesterol abnormalities, obesity, sedentary lifestyle, peripheral vascular disease. Again, if somebody has blockages in their legs or in their neck or any other place in the body, there's a high chance they're going to have blockages in their heart arteries as well. Excuse me. Now, know your cholesterol profile, okay? Go to your doctor. If you've not been checked, ask him to check your cholesterol profile. And there are some general guidelines on where your numbers should be. And it really has to do with whether or not you've got evidence of vascular disease or not. If you've got a couple of risk factors but you've never had any vascular disease, well then the goals are not as stringent. But if you've got heart disease, let's say you've had a stent or a bypass, or let's just say you've got some blockages in your legs, we need to get these numbers even lower. For instance, the LDL cholesterol is what most doctors focus on. If you've got a stent or a bypass or documented heart disease, generally that LDL should be around 70 or less. Okay? But this is a general number for people who have a couple of risk factors. All right? Now, the HDL is the good cholesterol, and again, that's a number that is a general guideline. How do we raise our HDL? Well, the higher the HDL, the better, okay? Because that's the good cholesterol. Well, we raise that by exercise primarily, okay? There's a vitamin called niacin. If taken in high dose, can raise our HDL as well. But those are primarily the two ways to raise HDL. Some of the statin drugs can raise the HDL, but just a smidgen. Now, the triglycerides. Of all within the lipid panel, the components of the lipid panel, the triglycerides are probably the most susceptible to dietary intervention. If you want to lower your cholesterol and you go on a strict diet, generally your cholesterol, or like your LDL cholesterol, is not going to change a great deal. But your triglycerides, you can have a huge impact on your triglycerides with diet. Another thing is fish oils as well. Now, know the signs and symptoms. Fish oils can lower your triglycerides as well. It's a good natural way to do it. Know your symptoms of heart disease or heart attack. And a lot of this is common knowledge, but a lot of people still get confused. Often shortness of breath and fatigue. A lot of people just think they're getting older, they're gaining a few pounds, they're thinking, yeah, I'm just more fatigued and short of breath than usual. But a lot of times it has to do with blockages or heart disease. Chest pain. We call it chest pain, but often it's not chest pain. It's generally a pressure-like sensation in the chest. People describe it as pressure, tightness, heaviness, a band around my chest. Okay? And or some people say it's like an elephant is stepping on my chest. It's generally not chest pain, but that's often how we describe it. The discomfort will often radiate into the shoulder, into the neck, and jaw. A lot of people will show up at the dentist's office thinking they've got a tooth problem because every time they take out the trash, they notice their jaw's hurting. Okay? Well, they go to the dentist doesn't find anything, and then he says, I think you ought to go see your cardiologist because that's a very common, we call it referred pain. All right? It's a very common description we hear. Now, often when people are having a heart attack, there's some associated symptoms such like sweating, nausea, some lightheadedness even. Usually the pain will last more than a few seconds, okay? Angina pain or heart attack pain will generally last for minutes. And simply a heart attack pain is simply angina pain that doesn't go away. Angina is the warning signs of an upcoming heart attack, okay? So you will go out and do some kind of physical activity, you get this heaviness in your chest, you stop the activity and it goes away. Well, that's a pretty classic description of angina, okay? Now, you go out, take that trash can out, you start having this chest pain, and guess what? It doesn't go away, and then you start sweating, you start getting nauseated. That's heart attack time. It's time to call an EMS service. And again, if you have a pain that is very transient, like lasting only a few seconds, like an electrical shock, that's generally unrelated to the heart. Now, how do we evaluate for cardiac conditions or cardiovascular conditions? Well, typically you want to start with your primary care doctor. Get your cholesterol checked, have them do a general screen or exam. And if they think their further exam or test are warranted, generally we're going to start with an EKG. And this is what a typical EKG looks like. Now, an EKG, a lot of times folks will say, oh, doc, thank goodness my EKG is normal. Well, guess what? A normal EKG doesn't mean you have a normal heart. Okay? There's a lot of people out there who've had bypass surgery with normal EKGs. There's even people who show up in the emergency room with a heart attack, and I've seen it on multiple occasions, where the emergency room doc says, I think this guy's having a heart attack, but his EKG is normal. I'm like, okay. So you go in, you talk to the patient, and guess what? You're having a heart attack. Let's go do something about it. So the EKG is great as long as it shows us an abnormality, but when it doesn't mean everything is okay. So in that instance, we generally want to go to some other testing called stress testing. Stress testing is typically our bread and butter testing for heart disease. And there's different types of stress tests. We can do a treadmill test where we walk on the treadmill hooked up to an EKG machine, and then we can do an imaging study such as an echocardiogram before and afterwards. There's also a nuclear stress test where we can inject this radioactive substance so we can image the heart. That's really probably our most sophisticated test and probably our best test. For those who can't walk on a treadmill, we have protocols that allow for pharmacologic stress testing where we inject medication. So just because you have some sort of orthopedic limitation doesn't mean you can't have stress testing. Now, when we want to get a better look at the heart, let's say we want to see how well the heart pumps. We want to check the valves in the heart. We want to look for leakage. We go to echocardiography, which is simply an ultrasound of the heart. And we image the heart from a lot of different angles. And we can manage flows. We can even estimate pressures inside the heart from all this. Now, what about newer technologies such as CAT scan technology? Well, CAT scans have been around for a long time. But what's happened is with some of the newer software and just the more powerful computers we have allowed for us to now image a moving structure. See, we've been doing CAT scans for years on structures that don't move, but now with the beating structure, we can actually take a look at the vessels. And this is some of the images we can create with CAT scan. I don't know how well y'all can see that back there. We can even color them purple and gold too, if you like. But again, look at how well you can see the blood vessels of the heart. Okay, I mean it's quite amazing. And this is a non-invasive test. You remember early on we talked about invasive tests carry with them some risk. Okay, non-invasive tests generally carry no risk. Now here's an example of someone who had a CAT scan that has had bypass surgery. You can see the bypass comes here, comes down. Here's another bypass coming down like this. And it plugs into the native vessels, you see. But again, this technology has come a long ways. And in fact, here's an example of a beating heart using the CT. And this one's a little bit crude once you're using the motion artifact. But once you've gone here, let me just go back 1 second. There we go. Once you've gone the non-invasive route and you've gone to stress testing or CTs and you're finding problems, the gold standard is a heart catheterization, coronary angiography. And the way we do that is we enter a tube, we numb the groin area, and we enter a tube, and we go up through the aorta, and it comes around like this. Then we can plug the catheter into the left coronary system, fill it with dye, and then we take that catheter out. A different catheter will fit into the right side, and we fill the right side. And there we will find if there's blockages or not. We can define the severity of the blockage and what can be done about it. Now, when medications are not enough with regard to treating heart disease, we resort to balloon angioplasty and stents. Right? This is common knowledge. This is nothing really new. I guess the newest development is the newer generation stents, the drug-eluting stents. And those have had a big impact on the restenosis rates. All right? We are seeing, in the past, our biggest problem with stents were the blockages came back, usually within 6 months, and we had to do something more, either another stent or bypass surgery. Well, now the restenosis rates, or the rate of the blockage coming back, is really in single-digit rates. It's made a big difference, these drug-eluting stents. But one of the, the limiting factors with these drug-eluting stents is that you've got to stay on blood thinners for a long time, like Plavix and aspirin, or at least aspirin for the rest of your life. Okay? I've had people who have had stents 2 years out. They have to go in for a surgery, stop their Plavix, and the stent clots off. Now that's rare, okay? Like it's less than 1%. But still, you do enough of these and you're going to see this situation happen. Now, if you're not a candidate for the balloon, obviously we go to the bypass surgery. And as far as new techniques in bypass surgery, probably the biggest advance that we've got here in Baton Rouge is we've gone to the type of surgery where we don't place folks on bypass. We call it off-pump. All right? In the past, when we do surgery and we open the chest, we stop the heart so the surgeon can operate on the heart. Well, nowadays, a surgeon operates on a beating heart. He's got a device now that sits on the heart and it kind of holds the heart still. So it allows him to tie that bypass into a structure that's not moving quite as much. And the benefits of that is the patients wake up so much quicker. They are much clearer because there's I don't think people realize it, but there's when we do a standard bypass and they have to cross-clamp this major artery, sometimes the plaque inside that artery is crushed and you can shower the brain with these cholesterol crystals. So that's why maybe a family member in the past who's had bypass, they woke up and they were a little bit foggy. They're coming out of anesthesia, God, I'm just so foggy. Their memory's maybe not quite right. Well, that's the reason for that. And so this newer technique where they're operating off pump has had a big impact on that. And people generally get out of the hospital quicker and they just feel much better. Now, we're going to switch gears a little bit here. And we're going to move on to the peripheral arterial disease segment. All right? You've been seeing a lot of that, more advertisements for peripheral arterial disease, or PAD. And the reason that's important is because people who have PAD often have heart disease and vice versa. And actually, if you were to take the populations of the smokers and the diabetics, those are the people who are going to get peripheral vascular disease way above anyone else. Okay? And here you can see 1 in every 20 American over the age of 50 is going to have some degree of PAD. Now, how does PAD develop? It basically develops just like heart disease develops. It's all an extension of the same disease process. It's just occurring in a different part of the body. And a lot of times people are not really keyed in or looking for it. Okay? However, if you can identify it early enough, it can be treated, and ultimately it can be result in saving a limb one day. Now, what are the common symptoms of PAD? Well, just like you get tightness in the chest when you have a blockage in the heart, you get tightness in the muscles when you try to walk. You start walking and all of a sudden your legs get real fatigued, real tired, and the muscle wants to cramp or tighten up. And you stop, and guess what? The fatigue or the tightness goes away. So you can walk some more. And then it tightens up again. That means that there's a blockage in the blood flow to one of your legs, or possibly both of them. And when you exceed the blood supply, when that muscle needs oxygen to work, it's not getting enough blood flow for it to do its job. Well, that's when it starts to want to fail or tighten up on you. When the blockages get even worse, you end up with foot or toe pain, even at rest. Okay? Even laying in bed, your legs or your feet can hurt because there's not enough blood flow. Gravity actually helps with the blood flow sometimes when you're standing. But if the blockage is so severe, when you're laying flat, you lose that benefit. It can get, obviously, progress even more to the point where you develop wounds. Okay? You also ultimately can develop gangrene and limb loss. Now, just like in heart disease, we talked about our bread and butter stress testing as kind of a basic workup or basic testing. Well, the ankle brachial index is a very easy test to do and is generally readily available in lots of doctors' offices, especially your cardiologist's office. But simply all we do is take a blood pressure, a typical blood pressure, and an ankle blood pressure, and we put the ankle blood pressure over the arm pressure, and if that index or that value is approximately 1, then you're in good shape. Once that starts to drop below 9%, 0.9, that's when you have an abnormality, okay? That's when there's a concern. And if we start to find these, these abnormal numbers, the next step is to image something and see what's going on. So we can image that, just like we can image the heart with an ultrasound or that echo. We use the same technology to image the blood vessels, okay? Here's an example of blood flow. And it's a very simple test to do, painless. Once again, CT technology is playing more of a role in peripheral vascular diagnostics as well. Just like we can image the heart, we can image a lot of the blood vessels in the neck. Here's an example of some carotid images here, okay? Here's the kidneys, and it's the abdominal aorta and the blood vessels going down into the legs. And there's just different types of images that we can create. Now, here's a little video just to show you the power of the CT angiography. What we're going to do is gradually strip away the outer part of the body, start to strip away the bone, and we can start to see the blood vessels now. And you can see the carotid arteries here, where the carotid artery starts to divide. This is generally where people have blockages. You can see they're like little rat bites. Same thing over here. That's the things that cause strokes. But typically you can't see these vessels on ultrasound. These are only things that you can see by CAT scan or angiography. But this type of testing, this non-invasive testing, is just phenomenal in what it can show us. And as you peel away the bone, again, you can just see all the vascular structures and what it can tell us. And again, this is all done in a non-invasive way. Look at that. See that blockage right there? And you can see some of the white stuff on the vessel. That's calcified plaque. And again, if you've heard of these things called calcium studies, all right? Well, they use the CAT scan, but they don't inject dye. Just a basic scan of the heart and or a blood vessel can show us if there's calcium. And let's just say somebody doesn't know if they have any kind of vascular disease. If we can demonstrate calcium in a blood vessel, guess what? You've got vascular disease. Now, typical common vascular problem, aneurysms, okay? Here's an image of CT image of an aneurysm. I think everybody knows what aneurysms are, and typically what this technology does, it gives us a complete look. We can take that and, like we just showed you, rotate it three-dimensionally in any direction we want to. And the thing is, once we've made that diagnosis, generally this can be followed with an ultrasound, once a year. Or we can follow it with a CT as well, but generally ultrasound is sufficient. And once the aneurysm gets to a certain size, it's time to operate. Here's another example. If once we go past some of the non-invasive testing, then we resort to the angiography like we've done in the heart patients. And here's an example. We put the catheter in just like we do for the heart patients, and we're imaging this area here. We can image the kidney vessels and all the vessels down in the legs. And here's an example of a blockage, okay? The white stuff is the dye filling the blood vessel. And this is where the blockage is, kind of like an apple core. Now, we can treat peripheral arterial disease a lot like we can treat heart disease. We can use balloons, we can use stents, and if we can get away with that and spare a surgery, then generally people are well served. However, in some cases we can't. We have to resort to surgery to fix those. And so you can see where we can bypass the blockage in this leg that's been plugged up here. Now, a lot of people can get by without bypass surgery because you see this branch vessel coming off here? It will often reroute blood and connect down here. We call that collateral circulation. The heart can do the same thing. Not everybody does it, but for the folks who do, it's often life-saving. But in limbs, the same thing occurs. We see a ton of people who show up with totally occluded arteries only to have this branch vessel filling the entire lower part of their leg. Okay? Well, that collateral circulation is generally going to last a long time. However, in some cases, the symptoms are so bad, and let's just say you're someone who says, I have to do a certain activity, I just can't live this way, I want something done. Well, at that point, we can resort to surgery and do bypass. Now, the bypass, unfortunately, the bypasses don't last forever. In fact, the bypasses in the legs tend to last for a lot less time than the bypasses in the heart. Why, we don't really know. But generally, if you can get 5 to 10 years out of a leg, you're good. Even 5 years, you're pretty good. So that's why it's important for early detection. If we can get to you before this point, we can come in, we can balloon it, we can stent it, we can put you on medications to try to slow the progression. I mean, that is the key. Now, again, we're going to change directions. Slightly, we're going to go to venous disease. Okay, a lot of people, you probably don't hear doctors talk much about venous disease. In fact, I think venous disease is probably, I guess you could say, the stepchild in the vascular arena, because really most people have not dealt with it up until recent. Because guess what? We've got some new treatment for it, and in the past it was just ignored. So venous disease can present as spider veins. A lot of folks know what that is. Varicose veins. Deep venous thrombosis. These are blood clots in the legs. Here's an example of a varicose vein. Blood clot in the vein. Here's an example of what happens, or some of the available treatment for these veins. A lot of folks who have these venous problems, for the most part, a lot of us don't feel them. But for some people, it feels like their legs are heavy. You know, they feel like at the end of the day, their legs and their feet want to hurt, and there's just a heaviness in their legs, a fullness in their legs. Well, part of it is because the veins, the little valves in the veins, and these are the valves here. You see the blood flows here? The flow through the heart is pulsatile. So as it's moving its way through the valve, it's to and fro. Well, these valves start to become incompetent. All right? So there's leakage. And the blood flow starts to flow backwards. And when the blood flow starts to flow backwards, it makes everything downstream balloon up. Okay? And when that starts happening, your legs just don't feel right. And a lot of people just think, well, I'm getting older, you know, I've gained some weight, and whatever. They don't really understand what's happening to them, and that there's actually treatment for it. A lot of people think that varicose veins is simply a cosmetic issue, and in some instances it is, but for a lot of folks it's a truly a medical issue. And it happens in people that are in careers where they're on their feet most of the day. We see it a lot in teachers and in nurses. All right? But especially in men who are, you know, standing around at a piece of equipment all day long. You know? This is also inherited. If it runs in the family, if mom and dad had it, guess what? There's a good chance you're going to get it as well. And so what you can do about this is we can insert, it's like an IV into the vein about this point here. We run a laser all the way through there. And what the laser does is it heats up this vein, and essentially it obliterates it. It causes it to close off. And guess what? The area where those leaky valves are no longer present. So everything downstream normalizes, and it reroutes through a deep venous system. And so their symptoms go away. And these you know, we see it more in women, but it occurs in men as well. So this is something that, again, don't think it's just cosmetic. All right? This has a medical indication, and there's good treatment for it as well. Again, here's an example of spider veins. Again, spider veins generally are cosmetic, and those can be treated with simple injections, a sclerosing agent. Now, getting back to peripheral arterial disease in general, just some quick facts. A lot of times people mistake the symptoms of PAD for something else. You know, they think, well, I don't know, I'm just getting older, or my back hurts, or they think it might be a nerve problem or something. It often goes undiagnosed by healthcare professionals, because you show up at your primary care doctor's office, and he may be focusing on your sinuses, he may be focusing on your arthritis, and really doesn't pursue that. And you know, you notice it, but you don't really tell him about it. You say, you know, doc, I'm noticing after I walk a couple of blocks or let's say a half mile, my legs tighten up on me. You know, if you don't tell him, a lot of times it's not going to be noticeable. And in fact, on the physical exam, he can check you physically, and he's not going to necessarily pick up something on the physical exam that's going to be abnormal, because I can check your pulses. Your pulses may still be pretty good. It's only until you exercise that the pulse, excuse me, that the pulse will drop off. And you know, people who have peripheral arterial disease are at higher risk for heart attacks and stroke. Excuse me, I'm nursing a cold here. Left untreated, PAD can result in a gangrene and amputation. I've got one, thank you. And again, like I mentioned earlier, smoking and diabetes, those two disease processes are devastating to the human vascular system. And if you've got a family history of vascular disease, and you add these two on top of it, you know, there's just no way to avoid it. So, what do we want to do? We want to take control. Take control by leading a healthy lifestyle. Let's get some weight off. Let's start exercising more. Let's eat a little different. And guess what? Go get yourself screened. You know, take your doctor's recommendations. You know, a lot of times I get people who are sent to me. They are asking their primary care doctors, you know, I'm 50-ish or 60-ish, and I've never seen a cardiologist. What do you think about that? And they say, you know what? I think it's time. Go get yourself screened for this or that. And a lot of times, when I see a patient, and what I have to determine with that patient is whether or not there's plaque buildup anywhere in the body. And we have these tests that allow us to detect that. Even though the blockages may not be severe, what it tells me is that we have to get more aggressive with your medical management, and primarily your cholesterol management. Remember early on when we were talking about the various levels of cholesterol? If we can diagnose plaque early, we can start treating it early and hopefully avoid the need for all these procedures down the road. And let me tell you, since the advent of the statin therapy, you know, like drugs like Zocor, Lipitor, Crestor, that family, it's incredible the impact that these drugs have had on our management of heart disease. And so, unless we can make the diagnosis early, we really can't impact the disease. And once you show up in our office with advanced disease, sure, we can do things for you, but at that point in time, it's limited to how far we can impact the advancement of the disease. We've got to subject you to a lot of different procedures at that point. So, timely detection and treatment can improve your quality of life, help keep you independent and mobile. You know, reduce your risk of heart attack, stroke, leg amputation, and even death. So, I think that hopefully we've been able to provide you with some information, a little more knowledge on why it's important for early detection of both cardiac and vascular disease. So, I'd like to open the floor now to some questions. I believe we have a few minutes. Yes? Yeah. Calcification is a normal, is sort of a normal aging process of the plaque. For instance, if you have plaque in your arteries at 40 years of age, it's generally not going to be calcified. And the reason we know that is because of the CT technology. Okay? Well, even some of the angiograms that we do. But with the CT technology, we can image the heart and show virtually no calcification, but yet you can have a 99% blockage. At that point, it's still fairly soft. As that plaque ages, usually into your 50s is when the calcium starts to get deposited. Okay? So when we do these calcium scores or these CTs on people in their 60s and 70s, a lot of times there's extensive calcification. Whereas when we do it in their 40s, even though we can see some plaque, the calcification is minimal. And so because of that, it has taught us how to use this technology based on the age group we're dealing with. But no, there's really, I think statins is not necessarily going to change the calcium content of that plaque.
So you can't get rid of the
Not really. All the statins do is help to slow the progression. And if you can take a 50% blockage and essentially stop its progression at that point, you've done a lot. Now, guess what? You can, maybe half the people in this room have 50% blockages in their hearts. It's probably not unreasonable to say. However, that 50% blockage, if I do a stress test on you, is not going to show up. Statistically, you're more likely to have a heart attack from a 50% blockage than a 90% blockage. Isn't that interesting? And the reason being is that there's generally more 50% blockages in the heart than there are 90% blockages. And as those blockages try to expand, that plaque is trying to grow, it ruptures, okay? And as the blood flow is flowing across that crack in that plaque, it's thrombogenic, meaning that the body wants to heal itself, so it's going to form a blood clot. It's just like if you cut yourself and you start to bleed, but then it clots. The same thing happens internally. Well, as that plaque is ruptured, the blood flow is flowing across it. It sees that, it forms a blood clot, and it tries to heal that vessel. But clot begets clot. Okay? The clot grows bigger, 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 and ultimately it stops blood flow through that vessel. And when that occurs, that's when the heart attack comes on. Those people that drop dead from heart attacks, who you talk to their friends and family and they say, he never complained of anything. Why? Because the blockage wasn't severe enough to cause symptoms. You see? And those are the people that when someone shows up at the hospital and I'm questioning them and I find out that they've had really no symptoms up until their heart attack, I know what I'm dealing with. I know I'm dealing with about a 50% blockage that has had plaque rupture and a clot has formed. So often I will go in, suck the clot out, and then guess what? I'm left with about a 50% blockage. I don't even have to do anything to it. I don't even stent it because it's not indicated. You see? So, but most people have warning symptoms. As the plaque gets more high grade, 80, 90%, those are the people that are going to start to get the symptoms, the warning symptoms. Yes?
Can I use my own blood pressure cuff to do the ankle blood pressure and the horizontal?
That's a good question. I've never had anybody ask me that. But yes, you can. You sure can. I would do it vertical. But you could actually do it either way. Yes, sir. In the white.
I'm going to all the screens they have. I'm somewhat everything checked out. Cholesterol, LDL, all the stuff. Listen to your presentation. What is my chance of coming to your office and have every test there is to be done for cardiovascular?
Right. You sure can. Well, I guess the answer to that is yes, you can. However, we generally don't recommend the invasive testing. Where we put in catheters inside of you. We're not going to recommend that in someone who's not having symptoms or if someone doesn't have an abnormal test. But if you want a non-invasive test, such as the CAT scan testing, which is an incredible test, the information we derive from that is unbelievable. And guess what? Guess what? Most of the insurers don't cover it. You know what? Let me just tell you what the CAT scan. I'll tell you what the CAT scan will do for you. And yeah, I mean, you can pay cash for it. In fact, in our office, if folks want to pay cash for it, it's $800. Okay? You might say, well, that's a lot of money, Doc. Well, it is a lot of money, but You know, it's not uncommon for you to go buy a piece of jewelry for your wife, spend $800, go get a flat screen TV, put it on your wall. You got one in every room. How much are you paying for that? This test is a one-time test, by the way. It's not a test I'm going to want to do on you every year. You know what it tells me? Once I see that you've got coronary disease or some degree of plaque in those coronaries, it tells me I've got to get more aggressive with your cholesterol management, assuming your cholesterol is out of whack. And let me tell you something. There's a lot of people that go to bypass surgery who have relatively normal-looking cholesterols. And what that tells us is that even though the number is relatively normal, it's the type of cholesterol flowing through their system is not right. And we can manipulate that with medication. Now, you show up, someone like yourself, and say, Doc, I would like to get screened for heart disease. Generally, we start out with a stress test. Okay? And if you say, Doc, you know, I've got some heart disease in my family, but otherwise I feel pretty good, is there anything else I could do to be screened in a more thorough fashion? And this CAT scan technology is unbelievable. I'll give you an example. I had a patient show up in my office, 72-year-old male. He was a carpenter. He built homes. I mean, this guy was in outstanding shape, muscular, physically fit, looked like a football player. I mean, you know, just incredible for his age. He comes in at one August afternoon and says, Doc, I'm just not feeling quite as energetic as I used to feel. And I guess I'm just getting older. I said, tell me something. Don't you have 3 brothers? He goes, yeah. I said, don't they have heart disease? He goes, yeah, they've all had bypass surgery. I'm the only one who hasn't had bypass surgery. I had done a stress test on him 6 months earlier. Passed it with flying colors. Okay? I said, you know what, we've got this new technology. I want to try it on you. And I want to see if you've been spared, unlike your brothers. We do the CAT scan on this guy. I get a phone call from the radiologist. He goes, Doc, we got a problem here. This guy's got severe disease. So we do an angiogram to confirm everything. He had what is called a widowmaker blockage. Everybody heard about that? Has anybody ever heard that before, that term? He was a walking time bomb. This is the kind of guy who his symptoms, he really wasn't having symptoms. It was just some, August. Everybody gets kind of worn out in August around here. And this guy would have just dropped dead. Nobody would have had a chance to save this guy. He'd have been out there building a house, dropped dead, no chance of survival. And because of this technology, we had just done a stress test on the guy 6 months earlier. Passed it with flying colors. But that's the limitation of stress testing. It's not 100%. It's not perfect. We have to understand the limitations of the testing that we use. And that's why we have all this gamut of technology available to us. And that's where we try to say, okay, let's start out with the more inexpensive test. Let's do the simpler test. We'll go to that. However, if you have a normal stress test, all that tells me is that you don't have a high-grade blockage lurking, all right? What these other tests, like the CT or this other test, the calcium score is part of the CT. Well, what they tell us is that you've got plaque, you've got vascular disease, you've got atherosclerosis, and guess what? That means we've got to get more aggressive with your medical management, okay? And we're going to have to be on the lookout. We're going to have to do some regular stress testing on you to make sure when that plaque gets, to a point where it needs some work, we'll do some work on it. But that's how we use the technology. And getting back to your original question is absolutely, if you want some screening tests done, there's no reason why we can't do that on you. It's just we don't do testing on people that are that's invasive where there's some risk involved, for. Sure. Absolutely. Absolutely. Yes, sir, in the blue.
Yes, sir. Because of the hidden factors of coronary disease, what is the medical community time frame on addressing plaque or any other type of coronary disease? Is there a certain time frame that folks should
Well,
this test taken or that test taken?
well, I would have to say it's not a really hard and fast rule on that age group, but it really depends on your risk factors, okay? If you come from a family where heart disease is present, people started having heart attacks, let's say a dad, an uncle, a brother, started having either a need for stents or heart attacks in their 50s or 60s, I don't want to wait till you're 50 or 60 to screen you. You see what I'm saying? I'd like to start 10 years or 20 years ahead of schedule. Because if I can screen you, like knowing what your cholesterol is, knowing what your blood pressure is, knowing what your weight is, and I can say, okay, guess what? You've got this family history, you've got some of these risk factors, we've got some time, let's start doing these things so when you get to that age, hopefully we can avoid what your family's been through. In fact, let me show you something real quick. I'm going to show you a study I did on a lady who did everything right. I don't know if everybody can see this, but let me freeze it. I don't know if I can freeze it here. I'm going to show you where the blockage is. Can y'all see that? Can you see that narrowing right there in that blood vessel? That's about a 90% blockage in the left anterior descending of a lady who was 55 years of age. Her mom had bypassed at 55. She did everything right. She exercised every day. She ate the right foods. Her weight was ideal. Perfect. And the reason I use her as an example is because this lady did everything right. She shows up at 55 years of age, has hypertension, has an elevated cholesterol, but I don't think the cholesterol was being treated very aggressively. She was being treated for hypertension, but it wasn't well controlled. But still, she did all the other things well. She comes in feeling fatigued, a little bit fatigued. She's exercising. I mean, this lady, they call it a fitness queen at work. All right? She shows up in my office, and you say, you know, we're going to go ahead. I really was not that impressed, to be honest with you. I mean, this woman, she could have been a 50-year-old model for, you know, AARP or whatever. But I put her on the treadmill. I said, I'll tell you what, we're going to go ahead and screen you. Let's go ahead and screen you for heart disease. We put her on the treadmill, and we did something called a stress echocardiogram, where we treadmill and we do an echo before and after. The entire front wall of her heart stopped working because of that blockage. You know, my jaw just kind of dropped. I was just not expecting that. This lady did everything right. It goes to show you how powerful family genetics are. Okay, despite your best effort, heart disease is still the #1 killer and probably always will be because it's just so prevalent and so powerful in our country. And plus, our eating habits aren't going to change anytime soon. But this is what we did for her. What we did was we put a wire in that vessel, and then we inflated a stent. This is the balloon, but there's two dark spots. I don't know if y'all can see that or not, but the stent sits between those two dark markers. We deflate the balloon, we remove the balloon, and then, voila, that blockage is gone. Can y'all see? Can y'all see that right there? When we put a stent in a blood vessel, we like for it to look like a snake that swallowed a rat. Okay? We like to see a step up and then a step down, just like you would see in a snake. And that tells us that, okay, this is a good implant. Well, this lady has done beautifully ever since. She went right back to her exercising. And we've gotten, you know, very aggressive with all of her management. And we've done a subsequent heart cath on her. And she has developed some disease inside of that stent. But fortunately, she doesn't need any further treatment at this point. Based on what I'm seeing, though, I'm afraid this is going to progress in her one day to the need for bypass, even despite our best effort. So the The bottom line is you can live with heart disease, you can live with vascular disease. It's a matter of identifying your risk early on, okay? Doing something about those risk factors, seeing your doctor, getting screened, and following their instruction. If it means putting away the cigarettes are huge. I mean, by far the most devastating thing we do to ourselves, okay? But our weight, okay? If we got a problem with weight, it runs in the family. Most people, being heavy runs in the family, okay? But also eating habits run in the family too. But in that case, it depends on the card we're dealt. We can be dealt a card where we're skinny, but a lot of skinny people get heart disease too. But being heavy leads to diabetes and hypertension. Okay? Also, it makes us inactive. Why? Because we just don't feel good. All right? So those are the kind of things we have to do for ourselves. Get in there, get screened. Okay? And like the gentleman said over there, you know, we have a healthcare system now where we're not really restricted. I mean, assuming you have the means to have a test done, okay, ask for it. It can be done, and it can be life-saving. It may not be life-saving that week, okay, but the fact that you've identified some plaque, that can impact you 15 years down the road, 10 or 15, 20 years down the road. Guess what? Those same treatments we use for heart and legs impact the brain. Statin therapy, guess what? Stroke rates are reduced on statin therapy. We'd been seeing trends of that for years, but no one ever designed a study to prove it. They finally designed a study to prove it, and guess what? We were right. It does reduce stroke rates.
So what is the medical community doing to possibly get more testing ahead of time?
Well, unfortunately, with the direction we're heading with healthcare in this country, that may be more difficult to do in the future with what's coming down the pipe. I think right now, with... I'm with you. I'm with you. But you know something? You have to be proactive. Okay? A lot of people go to their doctors and look for advice from their doctors. And it really, you know, some doctors are more aggressive than others. And if you're not necessarily satisfied with the direction that your doctor's going, you can always suggest, say, Doc, you know, I'd like to get screened for heart disease. And if you've got risk factors, generally in your 40s is a good time to start getting screened, all right? But if there's no risk factors in your family, or you have no real risk factors, I don't have a problem with you waiting into your 50s, really. Even into your latter 50s, to be honest with you, because if everybody in your family lives to be 90 years old, nobody has heart attacks, then there's a good chance you're going to probably follow that same path, assuming you live similarly, okay, and don't have different habits.
Okay, we're going to have to end it at this point. Let's give Dr. Fontenot a round of applause.